You begin when you're ready.
We ready to go?
Yes, we are.
All right. Great. Hello, everyone, and thank you so much for being here today. There's lots of people here, and we're so excited. My name is Miriam Bender. I'm Associate Professor here in the School of Nursing at UC Irvine, and I am Director of the School Center for Nursing Philosophy. I am very honored to be co-sponsoring this multidisciplinary event with Duncan and his center now for the second year in a row, and I am very much looking forward to Javi's talk today, which Duncan will now introduce us to.
Thanks, Miriam. Hi, everyone. So my name is Duncan Pritchard. I'm a professor in the philosophy department. As Miriam says, this event's an annual event now. It's co-organized by the two centers that we run, the Center for Nursing Philosophy and the center that I run, which is the Center for Knowledge, Technology and Society. And this lecture is also co-sponsored by the Center for the Medical Humanities. So we're delighted to have Professor Havi Kirell from University of Bristol here. She's had an incredibly distinguished career. I'll read out some of the highlights here. She's recently completed a Wellcome Trust Senior Investigator Award entitled The Life of Breath. She's awarded a Health Humanities Inspiration Award 2008 for this work. She's the author of Illness, which was shortlisted for the Wellcome Trust Book Prize, and of Life and Death in Freud and Heidegger. She's a co-editor of Health, Illness and Disease, New Takes in Film Philosophy and What Philosophy Is. Her third monograph, Phenomenology of Illness, was published by Oxford University Press in 2016, and she was selected as the Best British Lecturer in 2016 as well. So she's had an incredibly distinguished career, and today she's going to talk to us about vulnerabilized individuals and opaque institutions. Thank you.
Thank you so much, Duncan and Miriam, for inviting me. I'm really happy to be with you remotely. It's nice that we can come together across the Atlantic. And now I'm going to try and share my slides so we can get started. And technology permitting, we will be on our way. Okay, so I should start out by saying this is a joint work that I've been doing with fellow philosopher Ian Kidd, who's a philosopher at Nottingham University in the UK. I'm at the University of Bristol, and the ideas are very much kind of developed organically out of earlier work that Ian and I did on something called Epistemic Injustice in healthcare. And I'll give some examples along the talk. But in a way, the whole idea here is to take the notion of illness and to kind of broaden it out to capture something a little bit broader, which we call vulnerability, or as I shall explain, vulnerabilization, which is a bit of a mouthful, but there's a reason why we want to distinguish just general vulnerability from particular ways in which particular individuals or groups are vulnerabilized. Now, what illness has in common with other predicaments, as I'm going to talk about in a minute, is this idea of an opaque institution. And basically, what we've identified is a sort of juncture in which what we call opaque institutions, big, bureaucratic, jargon-heavy, hierarchical, compartmentalized institutions with complex processes, paperwork, form filling, interactions, and procedures encounter what we call these vulnerabilized individuals. So we're interested in two things. First is how individuals who are already vulnerable come into contact with what we call opaque institutions. And the second is how opaque institutions can increase the damage or worsen the predicament of these vulnerable individuals and vulnerabilize them even further. And I will be giving examples from the criminal justice system, the social care or benefit system, as it's called here in the UK, and of course from healthcare. So I'm really building here on a lot of insights from our earlier work. And obviously, the first kind of question you might say is, well, look, I mean, even ill people aren't a homogenous group, right? Because there's people who are chronically ill and people who are acutely ill. There are people who are mentally ill and people who are somatically ill. There are people who have diabetes, and what on earth do they have in common with people who have leukemia? And these are all really worthwhile questions. And what Ian and I tried to do in our earlier work on epistemic injustice, or what we call the epistemic predicament of patients, is really to try and identify the general ways in which people who are ill, and it matters which illness they have, but we also wanted to make a general claim about how such people are, if you like, the victims of stigma, of stereotypes, of a host of attitudes towards ill persons, which Ian in another paper calls pathophobia. So pathophobia are a host of attitudes such as, it could be dismissiveness, callousness, insensitivity, suspicion, lack of care. It could be a host of attitudes that attach themselves to our views of ill persons. It could be implicit bias, it could be explicit prejudices or stereotypes that we hold, and can cause epistemic and, of course, other kinds of damage to people who are ill. So the challenge for us was to take this conception of illness and to try and find the features that are shared across conditions as varied as I said, leukemia and diabetes, in order to say something in general about these stereotypes, stigma, and prejudices that attach to having that, being in that state, or having that status of being ill in itself. And then we did further work trying to talk specifically about chronic illness, which is quite a stable group of people who live with chronic conditions, sometimes for many decades. But then, of course, a very distinctive group would be that of mental disorder, or people who are treated psychiatrically, primarily because such people suffer an additional kinds of stigma and negative attitudes that are directed at them as mentally ill or mentally disordered persons, or persons with a psychiatric diagnosis. And I think the project that Ian and I started, I think our first paper came out in 2014, so in the last sort of 8 years or so, it proved successful in the sense that we managed to identify this set of pathophobic attitudes, and we, I hope you'll agree, managed to show how they lead to epistemic disadvantages, so to dismissiveness or lack of credibility attributed to people in virtue of them being ill. So if you think, for example, a classic example might be people who have, say, a personality disorder, and people who might know of their diagnosis might treat them with increased suspicion, or take their testimonies or the things that they report or say about themselves or about other things as much less credible than they would have otherwise if these people didn't have, say, a diagnosis of a personality disorder. So building on this kind of foundation, or this thought that there's a group of people, they're being wrongly stigmatized and have negative stereotypes attached to their identity qua patients or psychiatric patients, and then trying to think about ways to ameliorate that. We then started thinking about something broader than just epistemic injustice, which is this injustice done to a patient, to an ill person, in their capacity as a knower. So complaints might be disregarded, testimonies about their mental state might be disregarded, complaints might be treated with disdain, and so on. So there's a host of disadvantages or injustices that accrue to people in virtue of having being in this vulnerable position of being stigmatized as patients or ill persons. But then Ian and I thought, actually, there's a broader picture here, what we call, following Jose Medina's work on epistemology, what we call the predicament of patients. And what we mean by predicament is that it is broader than epistemic injustice, because there will be ways in which you are epistemically disadvantaged when you are asked, for example, to, as a newly diagnosed patient, are asked to navigate your way amongst the forms, the appointments, the jargon, the medical terminology, and the procedures that you're kind of thrown into. Okay, so the predicament of patients has to do with the broad ways in which people who are ill are disadvantaged or wronged or actually actively harmed, if you think about cases of patient neglect, for example. So despite the fact that, as I said, the group of ill people is a very diverse group, illness, I think, confers unique features that we call the predicament of patients that can be used to characterize quite generally what happens to people when they fall ill. Now, of course, when you fall ill, one of the first things that happens to you often is that you start having very close, sometimes intensive contact with big, bureaucratic, complex, hierarchical, jargon-laden institutions, such as the institutions of healthcare. It could be a hospital, it could be a health service, it could be a GP surgery. Sorry, I don't know the American equivalents to all these terms necessarily. And similarly, if you think about other big institutions we come up against, much of our life is lived in contact with institutions. And the more vulnerable you are, the more closely you rub up against institutions in your day-to-day life. So people who have chronic ill health have a lot of contact with healthcare institutions. People who have problems with their education might rub up quite closely against educational boards, educational psychologists, educational panels, and so on. People who come into contact with the criminal justice system are indeed come into a lot of contact. And again, if you think about the ultimate extreme cases of what I'm saying when I talk about contact with an institution, it could be something like being incarcerated, where you have no say on the matter and you are in contact with a criminal justice system or a penal institution 24/7 for the duration of your sentence. Similarly, if you're hospitalized, again, the contact couldn't be any closer. You are in hospital for the duration, however long you're staying there. So the point I'm trying to make is that our encounters with institutions can be unchosen, they can be foisted upon us. I'm not saying anything about whether it's right or wrong that this or that person is incarcerated. I'm talking about the general idea that you come into contact with institutions that have a lot of power, a lot of force, and a lot of processes and ways of working, many of which will be entirely opaque to you as an institutional user, if you like. So a lot of things, if for those of you in the audience who are academics, a lot of the behind the scenes processes and work that we do as academics are entirely opaque to our students. So when I was an undergraduate student, I thought my lecturers just sat in their offices and read philosophy books all day and just waited for me to come and knock on the door and ask them a question about the reading for that week. Now, of course, that's not the case. There's a lot of underpinning administrative or kind of management kind of work that happens in institutions. And there are all kinds of constraints and processes and limitations and reasons why things are done in a certain way. But all of this could be entirely opaque to a person who's not an institutional agent, doesn't work in the institution, like me being an academic who works at the University of Bristol, but is an institutional user, like a student, for example. So what Ian and I had thought was that there's an interesting juncture here, because you've got these big, complex, heavy, powerful institutions, and then you've got people who are coming into contact with these institutions, often without wanting to, but needing to come into contact with these institutions. Now, who are those people? So the example I gave of the group of ill persons would be a paradigmatic example of people who are vulnerable due to their illness and have to come into continuous contact with healthcare institutions, people who are, sectioned or, in a psychiatric institution, have to come into contact with that institution, sometimes, not always, but again, they're vulnerable in virtue of having a psychiatric illness, and then there's the institution. Similarly, a child with educational challenges or a learning disability might come up against, or rather the child and their family and their carers might come up against educational processes and bureaucracies that are opaque to them. Similarly, somebody who enters the criminal justice system might come up against a lot of processes, language, and occurrences that are not clear to them. So, as you can see, I'm trying to kind of paint a picture of a sort of David and Goliath, right? Because there's these big bureaucratic complex institutions. I haven't said anything yet about the intentions of the people working in the institutions or the ethos of the institution. We'll come to that in a minute. But what I'm trying to point to first is that the place at which the junction at which this encounter takes place is one of enormous power differentials. So there's this one person who's a diabetic, for example, and needs healthcare, and there's the institution of healthcare with all its machinations, power, and bureaucracy. And what happens, what we're interested in, is how that vulnerability of the individual person who is ill or incarcerated, and the opaqueness of these large institutions, how they meet each other in a way that we suggest makes people who are already vulnerable even more vulnerable through this process that we call vulnerabilization. Now, this is our first paper on the topic, and I would really welcome comments on actually the mechanics of vulnerabilization, because I think we started identifying some, but we're by no means done in finding them. So I'd be really interested if you have particular examples of processes of vulnerabilization by institutions that you can point us to. So now, this term vulnerability, it has a universal nature, right? So philosophers, and in particular, gosh, that was a lot of time spent on my first slide. Philosophers in particular, like say Alistair MacIntyre and Pierre Hadot, the psychoanalyst Sigmund Freud, these are just some of the kind of inspirations, I guess. Others as well, talk about vulnerability as a kind of universal feature of human life. And I really like this view because I think it is entirely true in virtue of us having the kinds of bodies we have that are limited and soft and frail and vulnerable, and in virtue of having the limited minds that we have that are forgetful and easily offended and vulnerable to emotional psychological pain, we are all vulnerable to a degree and share important vulnerabilities. So the fact that we are mortal, that we're all going to die, that could be one example of shared vulnerability, universal in fact. The fact that we can fall ill, that we can suffer, injury and accident and bad events can befall us. The fact that we feel pain and that we hate feeling pain. The fact that somebody can come along and break our hearts. These are all kind of universal ways in which we're all vulnerable. Now, of course, there are also other ways or conditions or situations in which some persons, so we have this universal vulnerability, but then some people are made more vulnerable than others. So it could be a social vulnerability, say, a particular social group, so women, might be thought of as not as academically or intellectually endowed as their fellow men in academia. So you could suffer social disadvantage, economic disadvantage, legal disadvantage, and of course it could be political conditions, such as, a racist regime in a country that will make some persons more vulnerable than others, and therefore subject to vulnerabilizing effects of various kinds of social injustice. Could be sexism, ageism, racism, ableism. Could be this pathophobia I mentioned earlier, and other forms of social injustice and discrimination. Okay? So all people are vulnerable, but some are more vulnerable than others. And it's that group I want to be looking at. Now, it's important to note that although we are transformed by vulnerabilization, nobody chooses to be vulnerable, right? Nobody chooses to be a member of a stigmatized and despised social group. Nobody chooses to be destitute. Nobody chooses to be a refugee. So vulnerability is forced upon us. And although it's forced upon us and it's never elected, it can still change us in really profound ways. And I'm emphasizing this point because I'm thinking here about the American philosopher Laurie Paul's work on transformative experiences, where she talks about how, when we decide to get married or what city to settle in or what sort of life to lead, we make choices that transform us, or whether to have children. That's her kind of famous example. Those choices lead to us being transformed in particular ways, for example, by becoming parents. But I'm really interested in how we can become transformed, or how we can change through events that are foisted upon us without wanting to. So, for example, here are 3 examples of changes arising from becoming vulnerabilized. They're not all negative, by the way. So many of them are, but here's 3 examples of transformations that are not negative. So illness, and this is again Ian Kidd's work in a 2012 paper, Can Illness Be Edifying? Illness, Ian suggests in that paper, can edify us. So we can fall ill and think it's the most terrible thing in the world, but then discover that we've become more thoughtful or more reflective, that we're better at prioritizing what's really important to us, and so on. So illness can transform us through its edifying powers. Other kinds of adversity can demand of us reflective coping. So for grief would be a kind of prime example, especially now in COVID times. We might have a reflective coping that only arises in us. We only learn to become that reflectively coping person because of our adverse experiences, for example, of grief and loss. And a third example is what the psychologist Jonathan Haidt calls post-traumatic growth, which is, he says, one thing that could happen when one undergoes a trauma, an accident or a divorce or a separation and so on. So I'm trying to kind of work on 2 levels here, right? On the one hand, I want us to keep in mind this idea that we're all vulnerable, that vulnerability is universal in many significant and fundamental ways. The other level is to notice the uneven distribution of vulnerability, because some people, we're all vulnerable in the ways I just spoke about, but some of us are really, really vulnerable through no fault of their own, no choice of their own. So despite the sharedness of vulnerability and it being a fact of life, it is often unevenly distributed. And this is one way of explaining the mechanics of social and other kinds of injustice, by saying the vulnerability has been unevenly distributed, or some people have been vulnerabilized. So vulnerability is both shared as a feature of human existence, and it's also lived in highly specific ways by each person. Now, I understand that in Miriam Center, I hope there'll be some or quite a few nurses listening, and I'm really, really interested in hearing from you, hearing your experiences, because I might be talking in these abstract concepts in this abstract way, But actually, when I think about vulnerability, I'm thinking about somebody who's lying in bed sick with COVID, and they're too weak to even talk. Okay, so that level of vulnerability goes right to the heart of, you know, what it means to be a human being. And it is a place that requires of that person and also those around them a very high level of courage, if you like, of of ability to withstand what is happening to them. So I'm not talking here in any abstract terms. I'm really thinking about somebody who doesn't have a roof over their head, somebody who's lying in bed and can't even ask for a drink of water. People can be very extremely vulnerable. And I'm going to come back to this right at the end when I think about the ethics of vulnerability, if you like, or of some of what happens in maybe end of life situations. So the thing I want us to hold in mind is that vulnerability is shared as a general feature of human existence of everyone, but also lived out in very different ways by different people. Now, of course, one is not born vulnerable. Well, they're born vulnerable in the general sense I talked about, but people can become more vulnerable through events and the actions of others, right? So if somebody suffers you know, if they're the victim of an attack on the street, for example, they could have PTSD and a physical injury and become very fearful of walking outside after dark. So people become vulnerable, they're not born that way, through events and the actions of others. And in particular, when we think about young people and children and infants, we know that the actions of others can be absolutely critical to the level of vulnerability that these people experience, these children experience. So people become vulnerable not just in the vague ether, they become vulnerable through concrete events and concrete actions of others. Okay, so if a teacher is insulting towards a child, or if a parent is neglectful towards a child, to a significant extent, that child can become vulnerabilized through these actions of others. And another distinction that we need to bear in mind is the difference between the intentional personal agents' actions, so the actions and intentions of individuals, and then the actions of institutions, and I'll come back to that in a minute. So people become vulnerable through events and the actions of others, and in particular, the actions and events that take place in and by institutions. So again, healthcare, education, criminal justice, social care. Now, a great example has been developed extensively by Shelley Tremaine in a recent paper, where she talks about care homes in the pandemic. And Shelley writes about I think it wouldn't be unfair to say, a deliberate callousness by decision makers who thought it didn't matter so much if COVID entered care homes. And I strongly recommend that you read the paper. And I think we've seen similar things have been said about the UK. Shelley's case is about Canadian care homes, where at the beginning of the pandemic, I think the sentiment that was reported to be floating around some political circles in the UK was that old people are very close to death anyway, so it doesn't really matter if people in their late 80s or early 90s or early 80s die of COVID, or it matters less than if young people die of COVID. So that's an example whereby a political or a management decision can come to impact on tens of thousands of people who, for example, live in care homes, and in one fell swoop can make them extremely vulnerable and and even dead. I mean, in the UK, there are tens of thousands of deaths in care homes in the early stages of the pandemic, because people were released from hospital back into care homes without having COVID tests. So that's one example. But what I want to do now is talk a little bit about the heterogeneity of vulnerability. So I'm again talking about pretty much everybody who isn't healthy and in the prime of life. So could be people with learning disabilities, people who suffer mental ill health, people with other disabilities, people who've had limited access to education, those who suffer domestic violence, people with neurodevelopmental disorders, the very old and the very young, and so on. So this is not an exhaustive list. This is just a sense of, I'm trying to give you who would be the groups who make up this bigger heterogeneous group of vulnerabilized individuals. Now, I don't think that this heterogeneity itself damages the coherence of the concept, because I'm pointing here to a particular social process or social structure where external features of the situation, economic injustice, political injustice, social injustice, for example, discrimination, can cause people to become vulnerabilized. Now, you could even go so far as to say, well, is anything really internal to us? So the people who are, I think people who are proponents of the social model of disability kind of gesture that thought by saying, disability is in society, not in individual bodies, if you like. Now, again, I'm going to bracket the whole issue about moral responsibility or culpability of those who are vulnerable. Because you might say, well, if people end up in the criminal justice system, it's obviously because they've committed a crime and they deserve to be there. I'm not dismissing that line of argument. I don't really want to touch on it, other than to say, this is about how people came to be in contact with the criminal justice system, or came to be in a situation where they are committing a crime, rather than their moral culpability. So here's what Shelley says. She's talking about this process of vulnerabilization. She says, rather than a prediscursive inherent human trait, vulnerability is a contextually specific social phenomenon whose politically potent and artifactual character could be recognized and acknowledged if feminist philosophers, among others, were to take up Foucault's idea of eventalization. Now, what does eventalization mean? Eventalization is Foucault's way of drawing our attention to the fact that many of the concepts that we have come to consider natural or even essential, like gender is I think a pretty straightforward example, are in fact the products of particular historical events that generated or created a concept that came to mean gender in the specific way that we might use it today. Now, the idea here is that if somebody is vulnerable, that's not an internal characteristic of their own bodies, minds, but rather, as she says, it's a contextually specific social phenomenon, okay? That people become vulnerabilized because they are the subject of discrimination or injustice or stereotype. And the idea of eventalization is meant to try and be a useful tool for us to unpick or deconstruct or take down these seemingly natural, timeless categories that we work with, like, again, say, a disabled person. So one is not born vulnerable, but vulnerabilities are created. Okay, so there could be what we might call situational vulnerabilities that are caused or exacerbated by the personal, social, political, economic, or environmental situations of individuals or social groups, including their interactions with institutions. Okay, so we're interested here in the way in which vulnerabilities are caused and exacerbated by political or economic or environmental situations. Now, here's a few examples. So say in the example of healthcare, they say, okay, they send you a letter for your appointment, and you are supposed to put it up on the fridge and note it in your diary, and at the appointed time to turn up at the right place and sit quietly in the waiting room until you're called, right? That's the kind of paradigm behavior. Now, consider some of the barriers or obstacles people might have in virtue of being vulnerable that might prevent them from doing something as simple as that. So some people have difficulties processing information and applying it. Some struggle to follow rules, so they might come into the waiting room but make a lot of noise, for example, or say, or be asked to go down the corridor to get an X-ray, but be unable to do that if they have, say, pathological demand avoidance. Many people have limited ability to organize and plan and act effectively. Some are unable to advocate for themselves, and this is a particular problem in psychiatry. Some are just very, very suspicious because of earlier life events of institutions and institutional agents like healthcare professionals, social workers, the police. Some could have, a sensory problem that means they can't tolerate the fluorescent lighting or the antiseptic smell of the waiting room. Some find it very difficult to go to unfamiliar places. So this is just, again, a very trivial example of saying, oh, why didn't you turn up for your appointment? And here are just some of the reasons why people can't turn up for the appointment in the way that, us neurotypical educated people think is very, very trivial and obvious. So what happens is, say, to continue with this example, you miss your appointment, you get, in the UK, if you miss a hospital appointment, you get referred back to your general practice, and you have to start the whole process of the referral again. People, I guess, occasionally get labeled as, difficult patients or something like that. But then if somebody aren't able to turn up for their healthcare appointment, they don't get the healthcare they need and can become even more vulnerabilized. So what we can see here is that the reliance on institutions for people who are vulnerable can be both more pronounced and more fraught, right? So if you have to go into the job center to sign for your benefits, as actually, I'm not particularly knowledgeable about how it works in the UK, but I think you had to go in physically and, sign for your benefits a couple of times a week. That could be a very fraught interaction for somebody who might have some of these vulnerabilities I was just describing in the previous point. But of course, that doesn't mean that you don't rely on the institution. And indeed, the people with the heaviest reliance on institutions can have the most fraught relationship with it. And again, I guess the criminal justice system is a prime example here. So what does it mean? What am I talking about when I'm thinking of what it is to vulnerabilize? So to vulnerabilize someone can mean, amongst other things, to impose, to intensify or exacerbate, to prolong or exploit a person's vulnerability so as to make them more harmful and to make that person's situation worse. Now, vulnerabilization can occur through careless institutional processes, miscommunication, very, very high up on the list of, why did things go wrong? And bureaucratic demands that can make practical things like travel nigh on impossible. So I had to go and visit my parents a couple of months ago in not very happy circumstances. And I don't know how many of you have tried COVID travel, but the number of forms you had to fill in and the number of PCR tests you have to take either side of coming and going and to come out of isolation and to return and to board a plane. I ended up spending sort of a whole day just trying to work out the requirements of the two countries I was traveling between. Okay, so that level of, if you like, epistemic labor required to do something as that was previously as simple as boarding a flight can actually mean that some people can't travel because you need to be very, very organized and to read the instructions very, very carefully. So vulnerabilization vulnerabilization can also arise from, going back to this point about miscommunication. I want us to think about the following case. So this person is about to come out of prison. They have a probation officer, and the probation officer fails to communicate with the housing officer to the effect that when this person comes out of prison, having served their sentence, they have nowhere to stay and they are once again homeless. Now, this is an example of vulnerabilization. You take somebody who's just come out of prison, you fail to sort out a place for them to live, they're out on the streets, they're further vulnerabilized because of, say, a miscommunication between the probation officer and the housing officer. Now, vulnerabilization as a term is also intended to emphasize that vulnerability has this dynamic character. So it's not a fixed state. Again, it's not essential, it's not internal, it's not a natural and immutable state. It is something that happens to people over the course, sometimes the course of a very long time. So what are these dynamics of vulnerabilization? So first, you could subject someone to violent or discriminatory or degrading behavior that can traumatize the person and cause them to adopt behaviors that increase their own vulnerability. So that's how they become more vulnerable in the first place. And second, you can further vulnerabilize them by particular behaviors. Again, abuse, neglect, violence, ignoring, overlooking, not listening, which again, it can actually cost people lives. So there are plenty of cases in the UK, just as an example, that the Mid-Staffordshire case in which patients, elderly and very frail patients, were neglected, and as a result, some of them even died of dehydration, of whatever. So people can become vulnerabilized through the actions of individuals and through, inappropriate or corrupt processes in institutions that become dysfunctional in a variety of ways. And then when the vulnerable person tries to resist the further vulnerabilizing behaviors, that person can incur further costs. So when you try to protest, when you're a whistleblower, when you try and call out a senior person's behavior, when you try and resist, arrest by police, for example, these could be events that cause further vulnerabilization. So the resistance of vulnerabilizing behaviors in itself often incurs costs that can be quite enormous and quite threatening and quite deterring for the person who is trying to resist further vulnerabilization. Now, here's an example. This is a quote from the Travelers movement. So the Travelers in the UK are people, I think, who move around quite frequently, who have a life form that is quite different to the one other people have. And here's somebody from within the Traveler movement saying what's going on. And this person writes, "There's been a lack of trust for a long time. You can't build trust instantly. The thing that will build that trust up is for the police to look inwards, stop looking at gypsies and travelers. It's easier to look at the community and say, it's you that are slightly dysfunctional. You're not talking to us. It's much more difficult to look at yourself and say, what is it about us that's stopping them from engaging?" So this is an example of how an institution, in this case, the police, can attribute a communicative failure to users. So it's you not talking to us, the travelers. And this person is saying, look at yourself and ask, what is it about us that's stopping them from engaging? And this is an institution, this is a call on an institution, in this case, the police, to become less opaque, to become more reflective, to scrutinize and explore ways in which it can become a more just institution. So thinking a little bit more about this idea of institutional opacity. So as I said earlier, institutions of the kind I was talking about are large, complex, bureaucratic, difficult to navigate. There's often jargon and local dialects, as well as particular norms and modes of operating. So are you allowed to eat in the waiting room? Can you shout if you've been waiting for 2 hours and no one's spoken to you? There'll be particular norms and ways of operating and behaving that would be acceptable within an institutions and ones that aren't. And all of these factors can come together and make some institutions epistemically opaque to their users. So the ill people, the people who've come to claim benefits, the people who are incarcerated or standing trial, but not to their agents. So again, think about this discrepancy, how much we know, we who are academics know about how our institutions operate and how much our students know. And what happens in opaque institutions is that values such as transparency, inclusion, being welcoming, being just, trustworthiness, could be stated in the institution's mission statement or welcome page, but institutional machinations actually operate against such values. And the result here is an epistemically unjust institution. So this is what we mean by opaque. We mean it's become epistemically unjust. It's become epistemically opaque to the very people who the institution is supposed to serve. So institutional opacity is characterized as a general tendency within large-scale and internally complex institutions to increasingly become resistant to forms of epistemic assessment and understanding. So I tried to fill in an American tax form today, and I found it very opaque. To the extent that I don't even know if I did it right. And I pored over a few web pages and I Googled and I kind of checked a few things. And for the life of me, I couldn't figure out, I needed to put in some number and I don't even know if the number I put in was the correct one. So this is an example of institutional opacity. This is, I guess, an institution that hasn't managed or hasn't tried hard enough to make itself transparent. Okay, so people who come to use it can very easily find the information they need, know where they need to go, understand what process they're about to face, can have an advocate to support them if they need, have a place to rest and get a drink of water if they need. All these things that each one on their own can seem quite trivial, can make all the difference between an institution that is transparent and inclusive and an institution that is unjust and epistemically opaque. Now, I'll say something about the epistemic effects of institutional opacity. That opacity can erode the user's epistemic confidence and their capacity to enact the appropriate styles of interpersonal presentation and epistemic performance. So I went on jury duty a couple of years ago before COVID. And all of us jurors were just so terrified of doing something wrong or saying something wrong when we were in the courtroom. We just kind of sat there really frozen. And that's an example for opacity, because we weren't quite sure what the rules were. Were you allowed to kind of scratch yourself? Are you allowed to kind of put your hand up and ask the judge something if you don't understand? How are you meant to address the judge? There's lots of, if you like, rules and norms that the outsider, the user in this case, us, the jurors just didn't know. Now, this kind of opacity, if it's something that you're confronted with time and again, can erode epistemic confidence, can erode people's capacity to have the energy and the creativity to find the appropriate style of presentation in order to be heard, in order to be listened to. And an opaque institution can also conceal the precise nature and operations of the relevant economies of credibility. So an institution might say, everybody is welcome. But in fact, say, take the example of racism, when somebody from a particular racial group turns up, then the clerk might say, oh, I just can't find the form now, you have to come back tomorrow. or a patient could be disbelieved despite the fact that the healthcare institution they are in prides itself on its inclusive and welcoming approach on its homepage. So opacity can erode solidarity, it can erode trust, it can erode the belief in the efficacy and the ethos of an institution. I'll quickly give the example of the Department for Work and Pensions in the UK. In the case of two women, Philippa Day and Jodie Whiting, unrelated, who both, for different reasons in different contexts, took their own life whilst waiting for their benefits to be reinstated. Philippa Day's sister testified that Philippa's poor mental health meant she was not able to handle the battle with the Department for Work and Pensions for the reinstatement of her benefits. And she wrote that her dealings with the DWP made her feel trapped and isolated from the world. And indeed, at least 69 suicides and suicide attempts in the UK have been linked to stopped benefits between 2014 and 2020. So what we can also see is that the effects of institutional opacity are far broader than just epistemic. So the mechanics can be epistemic, so institutions can ignore or silence people, but they can also do other things. They can abandon or harm or even kill the very people they are entrusted to care for. So the effects of institutional opacity can be far broader than just the epistemic ones. And again, I would mention here the Francis report about the Mid Staffordshire patient neglect case in the UK. So I hope I have made the kind of general case here clear. And I want to close by talking about those two levels, the personal vices versus institutional failings, to again offer this two-level analysis. So vulnerabilization can happen either because of an individual's personal vices, cruelty, callousness, ignorance, or because of institutional level failings. And what Ian and I suggest is that institutional failings, failure in processes, in efficiency, in transparency, are the institutional equivalent to a personal vice like cruelty, cowardice, and so on. So these two levels, the personal vices of individual agents of an institution and the institutional failings at the level of the institution itself, operate analogously to undermine and vulnerabilize particular persons and groups. And here's an example. So when I went to primary school back in the 1970s, every class had the stupid kid. Now, the stupid kid in the case of my class was a boy who had undiagnosed dyslexia. And he was labeled stupid. And the teachers who had dealings with him and with us, with the rest of the class, had very clear personal vices that shine powerfully to me across the decades that have gone since. They displayed the vice of cruelty. They were unkind to him. They were callous. They were hard-hearted when they saw how much he struggled. They destroyed his confidence. Now, those personal vices were also reflected in institutional failings because nobody sought an explanation for why this kid was stupid. No educational board was convened to give him support. A teaching assistant wasn't brought into the class to support him, and so on. And the idea here is that the personal vices of these teachers were mirrored by institutional level failings of the educational institution he was in, and resulted in lifelong vulnerabilization of somebody who grew up thinking they were stupid. Now, the institutional opacity here is this really opaque domain of education processes and educational law And good luck to anyone trying to make headway in understanding these two, at least in the UK. They're extremely complex. So these vices of individual teachers, being impatient, lacking in empathy, being short-sighted, were really mirrored by institutional opacity. Now, when Ian writes about pathophobia, he identifies 5 vice clusters that he calls aversion, banality, callousness, insensitivity, and untruthfulness. And it might be that similar vice clusters have to do when we think about the way in which we are prejudiced against other groups, not just patients, other groups of people. But the important point is that those 2 levels combine and ramify to further vulnerabilize individuals. Okay, right, this is my concluding slide. So I started by saying all lives are imperfect, or all people are vulnerable, but some are more so. And what I want to do now is want to look at the people that so far have spoken about as vulnerable, as vulnerabilized, as victims of a system, if you like. And to end on a slightly more kind of positive note, because what I want to do now is to illuminate the possibility that moral excellence and perhaps other kinds of flourishing are possible even under conditions that are non-ideal and even with limited resources and personal capacities. So the stupid boy I was telling you about a minute ago was always very kind. He was always a good friend. He was very funny. He had lots of other amazing personal capacities and character traits. And I want to use that in order to really make the general claim that we should not give up on the idea that we can find moral and other kinds of excellence and flourishing, even amongst those groups that I've so far spoken about as vulnerabilized, as people who are weak and needing protection and support. So what we ought to do, I think, is to ameliorate and reduce vulnerabilization wherever we can, but not unnecessarily narrow the space of flourishing. So I'm not saying here that all of these people who are vulnerabilized are kind of by definition excluded from the space of flourishing. On the contrary, I suggest that even those who are vulnerable, be that ill or disabled or disadvantaged in other ways, or the victims of social injustice and so on, are still able to display moral excellence and are still able to flourish even under difficult conditions. Now, this isn't a sort of Pollyanna-ish gloss of, pink glasses kind of thing, but rather, I think we need a much more fine-grained view. We need a much more fine-grained perspective when we look at particular groups, say infants or old people or whatever, so that rather than just looking at those groups and finding the vulnerabilities or deficiencies, we can try to start and look harder at how each, say, developmental stage has corresponding virtues, and that these ought to be studied and recognized and indeed celebrated. So what do I mean by that? Take a child with neurodevelopmental disorders, so fetal alcohol spectrum disorder, for example, which is acquired brain damage caused to the fetus by maternal alcohol consumption. Now, people with FASD have to face a lot of struggles in their life. They have problems with executive function, with memory, with the ability to emotionally regulate. They can't plan and remember very well. They struggle with concepts of time and money, for example. They find it difficult sometimes to remain in education and employment, and so on. Now, before we write off, say, the group of people with FASD or neurodevelopmental disorders, I want us to do the opposite. I want us to stop and think, what amounts of courage and excellence what amount of optimism and energy is required from a person like the one I was just describing to still get up in the morning and attend school or go to work or volunteer in a charity. So what I suggest is that vulnerability both requires and tests virtues in ways that can far surpass our kind of normal spectrum of what we consider to be virtue. And it also requires us to be adaptive and creative when we respond to the stuff life throws at us. So when we face our own vulnerability or that of others, we're provided with not just a normal opportunity, but really an exuberant opportunity to exhibit excellence by responding well to adversity. So I want to finish by saying what I've said about vulnerabilization goes both ways. We ought to reduce it and fight against vulnerabilization where we can, but we want to also leave open the door for people who are vulnerable or vulnerabilized to share with us moral and other kinds of excellence, to flourish, to have place or a stab at the possibility of a good life, which may not be the kind of good life that we imagine for ourselves or for our form of life, but would be one that would be equally valuable and equally ought to be recognized and celebrated. So that's it for me. And thank you so much for listening for quite a long time. And just to say, this is a list of the sources, so some of the stuff I've written in recent years, from which the paper has been cobbled together. The first and last item are open access, which means anybody can Google them and find the full text. The other ones, the middle two aren't. But if anybody wants copies of these papers, I would be very happy to supply them, and Brian will explain how to do this. So thank you so much for listening, and I'm looking forward to the discussion. Thank you.
Thank you, Javi. That was fantastic.
Thank you.
Yes, thank you.
And we've already have a series of questions. Duncan, did you maybe want to start the ball rolling?
Well, I think yeah, sure. Should we bring in the first question is Caitlin Nye? Should we bring Brian, if we could bring her into the room? That's okay, Caitlin.
Hi, can you hear me okay?
Yes.
Yeah.
Wonderful. First, I want to thank you so much for an excellent talk. One thing I've really noticed in my practice as an educator and as a nurse is the way that we even speak about vulnerability and sort of what that means within power dynamics in healthcare settings is so, it does a lot of work for us as nurses in those interactions for sure. But the question that I had actually put in the Q&A has to do with nurses and the ways in which the ongoing pandemic and other things have really highlighted some, we'll say, power imbalances in the relationships between nurses and the institutions within which they work. And I was thinking, was wondering if you'd be able to speak to sort of the use of that vulnerabilization in thinking not about patients or ill persons, but nurses and other healthcare workers in these environments as they have evolved, devolved, et cetera, during the pandemic. So thanks for taking my question. I appreciate it.
Thank you. Thank you so much. Wow, you would be so much better placed to answer this question than me. So I'll just say something general and just hand back to you if you have like a particularly salient example you want to share. I think that would be really, really useful for me personally. So I think you're totally right that the epistemic injustice and the other stuff I was describing can also take place in well, I guess everywhere where there's a hierarchy and everywhere where we make credibility attributions to other people who are speaking, then you could also find cases of what's called epistemic injustice, which is the way in which somebody's testimony or epistemic offering can be derogated or ignored or overlooked. And sometimes that could be, people could appeal to, to something allegedly objective. So sometimes people say, yes, we would include qualitative data in our guidelines, but we don't really know how to synthesize all this excellent quantitative data that we've got with the qualitative. So we decided to just not use the qual stuff. So that'll be an example of something that isn't directly of patients, but is of import to, because the qualitative stuff would be the patient testimonies. So I'll hand back to you, because I'm pretty sure you were thinking of a specific scenario.
I think I was thinking largely of the tension that exists in nursing around sort of nursing practice on the one hand, and the ways in which nurses do or don't exert power in those practices, but also nursing as paid labor. And so how that has been manipulated, exploited, utilized in particular ways in response to a true public health crisis. And so, a lot of what I see in my area locally, at least, is nurses really reevaluating just even the monetary worth of their work. But to me, there's something much more sort of like, as you were saying, like epistemologically problematic about that, about like, what is their relationship to these institutions in which they utilize this particular set of skills, and what does it mean to put a dollar amount on that? Similarly to what does it mean for a patient to either have or not have access to psychiatric health services that are needed, and like, what does that even look like? So I'm at risk of doing the thing of like, here's a question, but secretly it's like my idea that I've like, this has really got some great like ideas churning for me. So I really just want to say I appreciate you even sort of putting that frame in this nursing context.
Yeah, no, thank you so much. I think what you're saying is spot on. I mean, in the UK, there was this really kind of cynical thing where every Thursday at 8 o'clock, we were all meant to come out to our doorways during the first and second lockdown and clap for our carers. And then at the end of the year, there was this kind of financial roundup and pay rises and so on. And the health NHS workers got something like a 0.1% pay rise, which in fact wasn't a pay rise once you take into account inflation. And that that kind of says it all, doesn't it? That, the vacuous clapping, maybe not entirely vacuous, but the largely vacuous gesture, and then the slap in the face in the form of not giving a pay rise to people who literally died on the job. So yeah, so thank you for bringing that up.
Thanks, Caitlin. Miriam, do you want to take the next one?
Yes, I'm hoping Sabina would like to come into our Zoom herself in and ask her question. Ryan, could you help us with that?
While we're waiting, I thought that clapping, by the way, what's even worse is that the very people who imposed that tiny pay rise, they're also pictured clapping, that's what makes it so hard to stomach.
Yeah, definitely. It was not our finest moment.
Here we go. Hi, Sabina.
Well, I didn't really have a question. I was just thrilled and amazed and excited to hear Javi's ideas, especially in light of an idea that I just ran across earlier this week that I put in the chat, Travian Shorter's concept of asset framing, which is the opposite of what in nursing we generally tend to do, which is deficit framing, and how closely that connects with all you're saying about vulnerabilization. And then just making a plug for my own theory of nursing, which is definitely not a fix-it approach to nursing, but a living, caring daily, and growing in ways of caring. And yeah, so being whole in the moment and growing in wholeness, rather than nursing looking for the brokenness or what's wrong that we can fix, as though we were mechanics. Thinking of nursing as partners with those who come to us for nursing, and our first recognition of those persons is, their value as persons, their inherent value, their specialized values, who they are as unique person. So I don't really have any question. I'm just excited to study everything that you've said and go more into depth and see how it can enhance our work in the theory of nursing as caring. So thank you.
No, thank you so much, Serena. That's just really wonderful to hear. I think this idea of asset framing, I'm going to definitely look that up, because as I said, I think there's these parallel literatures going in these two different disciplines, and it would be so useful to come together for this. That's a really good way of putting it, asset framing. I think the problem with I guess the kind of traditional biomedical approach is that it's very kind of deficit focused. So when you're deficit focused, you focus on what's wrong and what you're trying to correct, and that's appropriate in lots of cases. But say in the case of the FASD child I was talking about earlier, you've got somebody who's got these real vulnerabilities and deficits, and then the question is, so what are we going to celebrate? What are we going to compliment them on? What sort of vision do we need to develop so we're able to see the places where they've been really courageous, where they've been really successful? And when you talk to parents of disabled children or go on those kind of fora, often they'll say, I don't know, my child said thank you to me for the first time in 15 years or something. And it sounds so trivial to other parents, but then as a parent of a disabled child, you might say, I totally get this. This is momentous given the context. So this idea that we need to relativize the way we approach or thinking about virtue and excellence and flourishing, so that we enable, as I said, other forms of life or other types of flourishing to emerge beyond the kind of, I guess, the very intellectual kind of Aristotelian idea that it is intellectual reflection or intellectual activity that is the highest and most noble form of virtue, and the thing towards human life is always intended. And it's not an easy task, and some people are naturally very good at it, and a lot of people are really rubbish at it. And I think if we could find ways to cultivate this,
it can be learned.
Exactly,
it's an approach that can be learned.
Yeah, and then again, I'm not glossing over difficulties and challenges, but I do think, especially in something like end-of-life care, it's the people, I've got a collaborator who's a music therapist, and she turns up with her little ukulele and helps people in hospices and palliative care to write a song that she then records and passes on to their family. And that is not an easy thing to do. And not everybody can, very few people can do that. And it's about how to cultivate those kinds of abilities to be empathic and to be with people in the place they are, in the place of deficit and suffering and diminishing abilities. That is extremely unique and extremely valuable and extremely under-theorized, I think.
Even end-of-life care, that phrase is what about celebrating life care? Or, some of the terminology we use in nursing and other helping disciplines it so ignores the person's resources.
Yeah.
And yes, if they come to us for help, we intend to help in the way that they want us to help. But our first framing and our context for our engagement with the person needs to be asset oriented, right? I mean, that's.
Yeah, I couldn't agree more. And I'm just sad that we don't have more time to, that healthcare is such a pressurized environment where there's so little time to do exactly that. But thank you so much for what you said and for giving me that reference. Thank you.
Thanks, Sabina. So the next person on the list is Mike Taylor. Would you like to come and ask your question?
Unmuting.
We
Video.
hear you.
Yeah, we can hear you.
So I'm a diabetes specialist, and so this question is embedded within an example. I was watching a case manager argue with a young single mother who was diagnosed with new type 1 diabetes about whether she should pay her rent or she should pay for the insulin because she didn't have insurance. This is a situation where, because it's type 1 diabetes, the patient herself, there's no lifestyle issue. She didn't create it's not a lifestyle kind of disease. And she actually has no other option to use insulin. She's in an impossible situation. The hospital doesn't want to provide her with initial insulin because it's too expensive. And the question is, what I saw in that situation was an accumulation of institutional opacity, in that the pharmaceutical companies, even though they say on their website, like you were talking about, our main priority is our patients, they literally charge 4 to 5 times what it costs to make a bottle of insulin. And so there was, even if the hospital didn't have a change of morality, if the insulin was less expensive, then maybe they could have provided some insulin. So there, in my mind, in that situation, was an example of an accumulation of opacity between institutions that just makes it even more difficult for a patient to deal with the situation when they're vulnerable.
Yeah, and that's the most poignant example of what I meant by predicament. I mean, what is a greater predicament? I really can't think of anything. Well, I don't know how somebody is supposed to not to resist vulnerabilization in that kind of situation. So yeah, I think it infuriates and saddens me, and I think, again, thinking about, I think we focus a lot on personal vices of a healthcare professional who was rude or curt or didn't order the right tests or whatever, whereas in fact those institutional or these policy level issues end up having a very kind of dominant purchase on people's lives in the starkest way, exactly as the example that you gave. So thank you so much for that.
Thank you.
And we have a term in nursing called moral distress and compassion fatigue, and that would be an ethical outcome perhaps of these concepts we're discussing. And to bring it to you talked about the epistemics at play, but then also, what are the ethics involved? And there's a question about in here that I would like Jillian, if she would like to come forward and ask the question, because I'm going to take my prerogative as a co-sponsor and say I'm interested in this question too. What is the relationship between the epistemics and ethics involved in these issues? Hi.
Hi there. Thank you for taking this question. Gosh, my heart is just beating. I feel like a fan. Thank you so much for the presentation. It was just wonderful. I've actually, to my best of my ability, used your work a little bit to try and. I'm a new nursing professor, let's put it there. So I just finished my dissertation not that long ago, but I spent the first 10 years of my career in the neonatal intensive care with maybe, it's not like a vulnerability Olympics, but, with such very, very tender vulnerable patients, and then their parents and their family as well. And my academic interest is around ethics and relational ethics, and it has occurred to me, and my dissertation was around the nurse's touch, so as an ethical encounter. And I think, you know, especially the way you closed, where you're talking about, of course, we need to get rid of, like, you know, we don't want people to be further vulnerabilized. And lots of ways that you said that we can change and we must change. And then at the same time, to recognize what I've been trying to think about is, I guess, this sort of power of vulnerability, which is, if we're open to it, this is how we can respond to our patients in the meaningful ways that they need to be responded to. So ethics in the sense of, you know, making contact with them, seeing them, but then also seeing what they really need. Of course, they need that too, but I mean, also in, like, what is the next best step that we can take together or alongside? Does that sort of, do you need more? I want to hear you more than I want to hear me. But so what I guess what I really appreciate is identifying vulnerability as not only a bad thing or something to avoid. We are all vulnerable. We are all made of, like you said, these pokeable bodies. And if I may, you know, one of the moments in your writing where you speak about, you know, having your diagnosis at that time or prognosis sort of confirmed. I believe you're with a lab tech, and you're of some kind, and you're sitting there and you're devastated, and they don't respond. Like, I think you ask for a cup of water and you get this sort of cup of water. And to me, like, that's such a clear moment in nursing or healthcare at all, where your response, even if we hadn't picked up what this might mean to you, your response makes it impossible for us to ignore if we let it.
Yeah, thank you. I've got just so many thoughts going through my head as you're speaking. And the one thought that I do have is that this is where, I don't know, whenever I talk to health professionals, I was just really moved by what you said. The wisdom of experience and practice is just so powerful to me that I feel really kind of humbled, as, you know, well, I'm a recipient of healthcare, but I've never been in that position where you have to offer that to someone in that particular way. So I think what you're suggesting, the sharing in vulnerability, is not a particularly easy thing to do, because I think when you're faced with vulnerability, the first instinct is to say, oh, that's them, right? I've got my uniform or my white coat on, and that's the magic that's going to protect me. And I think what happened with COVID, when a lot of health professionals became ill, and tragically some of them died, is that separation was broken down.
Yeah.
And again, going back to this idea that we're all in this together. Yes, we are all vulnerable to COVID, but boy, are there differences, and are these differences becoming more obvious with time? Indeed. So I think you're right. I mean, I'm just always really scared of kind of falling into sort of cliche and saying, oh, we're all vulnerable. What I want to try and do is kind of cash it out by explaining what gives rise to the vulnerability. So, you know, our physical bodies, our mental capacities, the fact that we're finite. And I think more than anything, I'm really at the moment thinking a lot of this idea of contingency, of thinking about how we're hostage to life's fortunes. And I'm very, very moved to think more about how, I guess, as Western educated, relatively affluent people, we always like to think that we are above that we can find solutions to every problem, and that we're, you know, more powerful than, I wouldn't say fate, but more powerful than these contingent things, events that strike us. And again, I think COVID has been really kind of unique collective experience of saying, no, actually, we're not. We're fragile in these particular ways. So now I'm thinking, okay, So what are we going to do with this? Say we've identified this vulnerability, we've cashed it out, we've explained its sources. How are we going to make that insight now kind of work, say, to make nursing better, to make healthcare better, to make patient advocacy better, to make communication in the clinic better? Do you see what I mean? So that's where I think, I think philosophers and nursing philosophers can really join forces. So yeah, I would love to talk more with you and anybody in the audience who wants to think more about how to translate the concepts I offered in the framework I offered into something that could be used for training, for professional development, for patient toolkits and so on.
Thanks.
Thank you.
Thanks, Julian. So we're going to bring in Sally Thorne now. That's a very interesting question about the virtues.
And I'll take the opportunity while she's coming on board to say this is Sally is somebody who I sent you one of the papers about the aligned concepts with your tailoring norms. So hi, Sally. Thanks for being here.
Oh, thank you so much for a wonderful presentation. I'm totally convinced of the value of this lens of vulnerabilization in thinking about some really important problems in healthcare and nursing. I'm a nurse from Canada, and Canada's had really had to pay very careful attention to all of the things that it's done historically with regard to Indigenous populations in particular. And that has really shaped our interest in being able to think about these ways in which we've been individual and systemic agents. In contrast to nursing theories, which I'd say probably give many nurses the illusion that they're being good people and doing good things all the time. They've taken them up almost as a bit of rhetoric that helps them avoid being overly critical. So this lens is a great one that I think for our purpose can be incredibly helpful. I wanted to ask you though, toward the end, I was trying to find sort of where are the solutions, and this is a complex and tricky issue. And you went to the virtues and to moral excellence, which I don't disagree with at all, but I found myself wondering if the language of something like moral excellence takes us into feeling that that's for the exclusive purview of those very few people who can achieve excellence. And is there a way to reconcile that with what we are trying to do, and in the sense of opening up a conversation that everybody can feel a part of, and everybody can feel a part of being part of the solution as opposed to continuing being part of that problem?
Thank you so much. I'm delighted to meet you because I've read your papers, and it's just it's always such a fun experience to see somebody you've kind of admired on print, as it were, for a long time, that you're a real person. So yeah, I really learned a lot from your paper, Sally. So here's my idea, and that's really in the 9-year-old hero. It's like a 2-page little thing I published. So I'm happy to send you the PDF. It's a kind of 10-minute read, as they like to say online now, before we endanger our lives by starting to read anything without knowing how long it's going to take. So what I thought was that we should take Aristotle and this framework of virtues and just open it up, in the sense that we relativize, we have sets, we have a menu of virtues, and we have a different spectrum, a different way of operationalizing the virtues, depending on the population we're looking at, right? So say in the case of the FASD child, for a kid with those kinds of deficits, sometimes just shutting the front door and heading out into the world is something to be celebrated. And again, I think there's just, within philosophy, for obvious reasons, because, philosophy is taught and done usually by a particular group of people, but I think that shouldn't really stop us from kind of correcting or expanding this Aristotelian idea that flourishing is a goal, by refusing the idea that there's only one goal or only one way of flourishing, and saying there could be lots of ways in which we could identify moral excellence or other types of excellence. But I'll say something in particular about moral excellence, why I insisted on that, because I think often you see somebody lying in their hospital bed, they can't move, they can barely speak, and you say, oh, this person, what sort of flourishing, what sort of excellence are they displaying? And actually, I think the courage it takes to be seriously ill, the courage to maybe face the closing days or weeks of one's life, the courage to age, you know, now I'm kind of, I think about that quite a lot these days. Our capacity to be with people in those situations, they require enormous excellences, except we haven't articulated them, because we're saying, oh, that's just a sick guy lying in a hospital bed, he can't do anything. But actually what we need to do is draw out of these situations the excellence and the flourishing and the capacity and the virtues that I think are going unnoticed, very sadly, because of the way in which we conceptualize illness and, to an extent, disability. So I hope this helps.
It does. It's very helpful. Thank you so much.
Thank you, Sally.
So Javi, I think you've given us all our marching orders. We'll have to have you back for many more talks. There were questions that we couldn't answer, and apologies for that, but it is already 11:34. We've gone over. So we do want to say thank you so much for coming and talking to us today, and such generative, rich ideas for thinking with. Duncan, did you have anything to add?
No, thanks very much. It was a fascinating talk. Havi, much appreciated. I think we have, as Miriam says, we have about a dozen questions unanswered there, but we're out of time. But maybe people can drop you a line. Would you be happy with that if they wanted?
Absolutely happy to be emailed, to send people PDFs. And what would be really helpful, Ryan, is can you capture the Q&A and email it to me? Would that be okay?
Sure thing, yes.
Oh, great, because this way I can look at all the questions. And again, very happy to be emailed, and I'd be really happy, Miriam and Sally and Gillian and everybody, to carry on talking specifically about the kind of nursing philosophy and nursing theory that might kind of emerge from this.
Oh yes, we will be in touch, most definitely. Okay, Ryan, did you have some final slides?
Yeah, let me put those up really quick.
And up.
Yeah. All right, so if we can all see this, just the first really quick is the next event that the Center for Knowledge, Technology, and Society will be putting on February 18th. I've dropped a link into the chat, and this will feature Andrea English from the University of Edinburgh discussing Dewey, uncertainty, and non-affirmative democratic education. And this is as part of the our annual Epistemology of Education lecture. And then the next thing that I have is for the Center for Nursing Philosophy. Miriam, did you want to say anything about this? I can also drop a link in the chat for this one as well.
Sure, yeah, just the link is open. Our registration and abstract submission period is open right now. Conference will be here in August. The theme is, what has philosophy ever done for nursing anyway? So wide, broad swath. Welcome your thoughts and ideas.
So thanks, Ryan, and thanks for everyone coming along to this session. And a final thank you to Havi for an excellent talk.
Thank you so much.
Havi.